Thanks to ACMP for the opportunity to present this first global registration program in this patient population. These are my disclosures. I'm a full-time employee at Janssen, as are my colleagues, a shareholder of J&J stock, and I will be talking about an off-label indication of patients treated with esketamine who had imminent risk for suicide. So I believe everyone in the audience knows that esketamine is the S enantiomer of racemic ketamine. It's a non-competitive NMDA receptor antagonist. Thanks to Patricio, who gave a very nice overview of the putative mechanism of action of esketamine and ketamine, which we believe results in its novel rapid antidepressant effect. Esketamine has 3 to 4 times greater affinity for the NMDA receptor. So this allows us to use a lower dose and a lower volume of medication, making it suitable for intranasal delivery. Suicide is a leading cause of mortality, and major depressive disorder is the condition that's most frequently associated with suicide. Yet, patients who have major depressive disorder with active suicidal ideation and intent are typically excluded from clinical trials of antidepressants. And further, the treatment options available for these patients are limited. Typically, we hospitalize patients, but hospitalization is temporary, and patients remain at high risk for suicide post-hospitalization. We also start antidepressants to treat the underlying condition, but as everyone knows, they have a delayed onset of action, so they're of limited utility in a psychiatric crisis. We conducted a phase 2 study of esketamine in the context of standard comprehensive, in the context of comprehensive care, standard comprehensive care. And in that study, we saw a rapid reduction of depressive symptoms at 4 hours after the first dose, with some benefit on indices of suicidality. So that gave rise to the global registration program and the data which I will present today. So we conducted 2 large-scale phase 3 studies called Aspire 1 and 2. They were identically designed with the exception of the regions in the world in which the studies were conducted. The primary endpoint was the change in MADRS total score at 24 hours after the first dose. And the key secondary was the change in baseline in a revised version of the Clinical Global Impression Severity of Suicidality, also at 24 hours after the first dose. So here's the basic schematic of the study design. Now, given the vulnerability and the novelty of this patient population for a clinical trial, the studies were conducted in the context of comprehensive standard of care. And by that, I mean that all patients were initially hospitalized and all patients had a newly initiated or optimized antidepressant started. The studies were designed to include about 224 subjects in each trial. And all of the subjects who participated in this study had major depressive disorder with active suicidal ideation and intent. And all of the patients were seeking clinical treatment for a psychiatric emergency. So they were presenting in an emergency room or recruited shortly after admission to an inpatient hospitalization. After a brief screening period, patients were randomized to receive either intranasal esketamine at 84 milligrams or placebo, again, in the context of standard of care, so additional antidepressant as well as hospitalization. And they were dosed for twice weekly for 4 weeks, with the goal of bringing the symptoms under rapid control after the first dose, and then to continue dosing for a total of 4 weeks to bridge the gap until the time it would take a standard of care antidepressant to exert its effect. And then after the 4-week double-blind period, patients were followed for an additional 9 weeks of follow-up, where they were just treated with a standard of care antidepressant at the discretion of the treating physician. It's important to note that to maintain the blind within this study, we utilized separate raters for both efficacy and safety. So here are the demographics of the patient population. The demographic features and characteristics were generally similar across both studies and across both treatment groups. About 60% of the subjects were female, and a mean age of about 40. Now, the background antidepressant could be whatever the treating physician wanted to use, and randomization was stratified by whether a patient was receiving monotherapy or augmentation therapy. And you can see that in Aspire 1, the first study, slightly more patients were receiving monotherapy, and the opposite was true in the second study. The patients were severely ill. The baseline MADRS score was about 40, and to my knowledge, that's the most severely ill patient population in a large-scale depression trial that I am aware of. 90% of the patients in the study were rated to be either from moderately to extremely suicidal on the CGI severity of suicidality scale. As I said, patients had to have active suicidal ideation with intent within 24 hours of randomization. But you'll see that over 60% of the patients had a prior suicide attempt, and about a quarter of them had a suicide attempt within the 30 days of randomization. And essentially, those patients were presenting having had a suicide attempt at the index. So this was a severely ill group, and it's important to point out that prior suicide attempt is the most important predictor of subsequent suicide behavior. So each of the studies met the primary outcome parameter, the MADRS, at 24 hours, with a mean difference of about 4 points in both of the studies and an identical p-value of 0.006. Because the studies were similarly designed and the outcomes were so similar, I'm going to present the remainder of the MADRS data as pooled data. And here we're looking at a subgroup analysis on the MADRS at 24 hours. So we see a variety of different demographic factors, including sex, age, race, and region of the world, all favoring esketamine and consistent with the overall effect. The same was true when we look at important baseline clinical characteristics, but it's particularly true for patients who had a mean baseline above the median split of a MADRS score of 41, as well as patients who had a prior history of suicide attempt. And there was essentially no difference in the patients who received either monotherapy or augmentation therapy as the background antidepressant. When you look at the individual MADRS items, generally we see that there's a benefit of esketamine on all of the items consistent with all of the overall effect. And here we're looking at the MADRS over time, and we did see a numerical difference for esketamine at all time points, beginning at 4 hours, and that continued through the day 25 double-blind period. So even after the standard of care antidepressant had time to exert its full effect, there was still an advantage for esketamine. The key secondary was the CGI severity of suicidality. And in each of the studies, patients in both treatment groups improved from baseline, but there was not a statistically significant difference on the CGI. And this may be due to the nonspecific beneficial effects of standard of care, particularly hospitalization in diffusing the suicidality within 24 hours of coming into hospital. But when we look at the various subgroups, again, we do see that the point estimates favor esketamine on a variety of demographic factors. And once again, we did see an advantage for the patients with the higher MADRS score at baseline and the prior suicide attempt at baseline on the CGI. On a variety of suicide indices, in addition to the CGI severity of suicidality, we looked at the MADRS suicide thoughts item. We looked at a CGI specifically around suicide risk, as well as frequency of suicidal thinking, rated both by the patient and by the clinician. And on each of these measures, at all of the key time points, the point estimates favored esketamine. So with respect to safety, we saw more treatment emergent adverse events, as well as adverse events leading to discontinuation in the esketamine group during the double-blind phase, and that's not surprising. We saw slightly more serious adverse events in the placebo group. In the follow-up phase, sadly, we did have one death occur in the study in a patient who had been previously treated with esketamine. This was the only death across the entire phase 2 and 3 program, and I think is really testament to the excellent clinical care that the patients in the program received. The AEs and serious AEs were similar in the two treatment groups during follow-up. When we look at the common adverse events, they're very similar to those known to be associated with esketamine and ketamine, the most common being dizziness, dissociation, and nausea. And to conclude, this is the first global registration program in patients with MDD who have active suicidal ideation and intent. And I think that fact alone is important, that we know that these patients can be safely managed and studied in clinical trials. In both of the studies, esketamine demonstrated clinically meaningful and statistically significant reduction in depressive symptoms at 24 hours compared to placebo in the context of standard of care. The treatment effects on the MADRS numerically favored esketamine at 4 hours and through the day 25 endpoint and across all of the MADRS items. While patients did improve with respect to their suicidality in both treatment groups, there was not a statistically significant difference there. However, subgroup analysis on both the MADRS and the CGI did show that treatment favored esketamine, particularly in patients who had a history of prior suicide attempt. And with respect to safety, and adverse events were similar and no new safety signals were identified. So just want to thank my colleagues at Janssen, the PIs and investigative sites that participated in the program, and importantly, the patients and their families. Thanks.
So thanks very much, Carla, for that presentation, and we have time for a few questions.
Thanks. Most measures for depression severity or suicide risk are psychometrically designed to capture the last week, 2 weeks, etc. Did you have to modify the MADRS, the CGI, and to psychometrically validate it?
Yes. So for the MADRS, we have a Janssen, because we're using the MADRS as an endpoint for a rapidly acting antidepressant, validated its use at 24 hours. For the earlier time point of 4 hours, we don't carry forward, or we don't use the sleep item, and we carry the baseline forward. So that's how we've managed the MADRS. With respect to the CGI, the reason we specifically used the CGI and a novel instrument called the Suicide Ideation Behavior and Assessment Tool, which informs that rating, was specifically because we wanted to make sure that they were assessing patients at this point in time and since the last visit, so that you could look at an immediate effect. And I can talk to you more about the psychometrics of that and the validation.
I just wanted to know, are you seeing any urinary symptoms as side effects, like bladder, either urinary retention or frequent urination?
Yeah, so we know that in chronic ketamine abusers that it can cause an interstitial cystitis. So we've monitored for that carefully throughout our development program in both treatment-resistant depression and in this program where we use specific scales to assess that. But we have not seen any other than, occasional urinary tract infection, which we see in both treatment groups. But that is, that was a side effect of special interest that we specifically monitored for through the program.
Thank you.
Hi, thanks for the nice talk. Is it factored in at all number of past suicide attempts, or is there a cutoff threshold for inclusion criteria, or on any of the analysis afterwards, was that delineating at all?
So we did not restrict on prior suicide attempts. So like I said, in the subgroup analysis, we do see this larger treatment effect in that patient population, but we didn't prohibit or limit, that prior history.
Okay, or in terms of parasuicidality or lethality of the suicide, that sort of stuff?
So we did, to the best of one's ability to make an assessment in an emergency situation, try to exclude patients who had borderline personality disorder, and we really trained the investigator to not only adhere to the letter of the protocol, but also the spirit, and try to include patients whose suicidality is really being driven by the hopelessness and despair of their depression, rather than a situational crisis.
Okay, we have time for one last question if it's very quick.
Sorry, I just want to make sure that I heard it clearly said by you. The esketamine did not beat the placebo. Is that correct?
On the secondary, so it did meet its primary outcome parameter on the 2 studies, so we have 2 positive studies. We did not see a treatment difference on the CGI SSR in either of the studies.
And so given that racemic intravenous ketamine in almost all the studies that we know of usually does beat placebo, how do we go forward justifying to insurance companies, government payers, our patients, what's the path forward here?
Well, that's a long answer. I'll defer to the organizers if you want me to give a brief response or.
Maybe you can talk about it afterwards in more
Okay.
detail, because we're almost on time, and so I want to introduce the next speaker.
Okay.
So let's have a hand for Carla